Next, we would like to invite Dr. Priyambada Maitre from Mumbai. She is a radiation oncologist and she'll be speaking on BART, acute and late toxicity from a phase 3 multi-center randomized control trial.
Good morning, everyone. Thank you, organizers, for giving me the opportunity to talk about bladder adjuvant radiotherapy, the BART trial, acute and late toxicity results. The PI of this trial is Dr. Vedang Murthy from Tata Memorial Center, and I'll be presenting on the behalf of our team today. So the acute and late toxicity results from this trial were presented in the late-breaking abstract session at ASTRO last year, and the full paper came out in Red Journal at the same time. There was even a podcast by the Red Journal. But the concept of adjuvant radiotherapy for muscle-invasive bladder cancer after radical cystectomy was something very new when this trial started. Because most of us would hesitate when we are thinking of doing radiation to this post-operative bed where there is a lot of bowel. Neither the surgeons nor the radiation oncologists would probably be too enthusiastic about irradiating all the bowel. So that is why this trial's toxicity results were quite important. And why was the trial done? The hypothesis was to improve the loco-regional control. And this is important because it has been known since a long time that the patients of bladder cancer who have local control do much better than the patients who are not locally controlled. So in essence, this reduces the risk of distant metastasis. Second, neoadjuvant chemotherapy we are all using as a standard of care for muscle-invasive bladder cancer. This is one of the trials which has shown a proven overall survival benefit, but there was no difference in the loco-regional recurrence rate, even after addition of chemotherapy. So we need something more to improve loco-regional control. Now there are many series in the post-cystectomy situation, mainly from University of Pennsylvania, also our own data from Tata Memorial, and some data from Korea and Europe also, that about 30 to 40% patients have a loco-regional recurrence after cystectomy over the next 2 to 5 years. And the risk factor contributing to this local failure are advanced T-stage, nodal involvement, less than 10 lymph nodes removed during surgery, presence of lymphovascular invasion, and margin positivity. So based on these risk factors, this trial was launched. This is a multi-centric phase 3 randomized controlled trial. The protocol has been published in detail previously, and 4 centers across India participated. This is the trial schema. So patients post-cystectomy having any of these high-risk features, after completion of neoadjuvant or adjuvant chemotherapy and surgery, were randomized to either standard arm of observation or test arm of adjuvant radiotherapy, 50 gray to pelvic nodes and cystectomy bed. Primary endpoint of 2-year loco-regional failure-free survival. For radiotherapy planning, we use global consensus guidelines to delineate the cystectomy bed CTV. We started 2 centimeter above pubic symphysis to penile bulb inferiorly, and all the regional pelvic lymph node stations were covered. We gave strict attention to the stoma for sparing of the lower dose. The ileal conduit, bowel bag, anorectum, femurs, and neobladder were all rigorously spared. For planning, everyone underwent IMRT technique with daily image guidance. There was strict sector avoidance used for stoma during the radiation planning, and attention was paid to the maximal bowel sparing. So you can see in the dose distribution, even 50% dose is not going anteriorly to the bowel. Now the results. 153 patients were randomized, and radiotherapy arm had 77, observation had 76 patients, of which toxicity was analyzable for 63 patients in radiotherapy group and 71 for the observation group. Some patients did refuse RT, or they were found unsuitable for starting the radiotherapy. They were still kept on the trial, and their toxicity was analyzed along with the observation arm. Our cohort, median age of 57 years, 20 removes were removed in each patient. Margin positivity rate was quite low, so the surgery was really good in this group. As expected, most of the patients had a high locally advanced bladder cancer, And importantly, 90% of them received systemic chemotherapy in some form. 70% was neoadjuvant, which is far higher than the general real-world practice, which is about 40 to 50% patients get neoadjuvant chemotherapy in the real world. 40% cohort had nodal involvement, and 1/4 had some component of variant histology also. Acute toxicity, we were really happy to see that there was no toxicity-related radiotherapy stoppage. Grade 3 side effects were really low, less than 5%. So in the observation arm, there were complicated UTIs in 3 patients, and RT arm, there was acute intestinal obstruction in 1. And grade 2 events were more in the radiotherapy arm as expected. Most of these were bowel symptoms like diarrhea or abdominal bloating. 1 patient had ureteric stricture, and in the observation groups, 1 patient had subacute intestinal obstruction. For the late toxicity, this was also really encouraging to see that there was no difference in the late toxicity. So the grade 2 bowel effects seen during the radiation resolved over time and did not lead to consequential late effects. Grade 3 and 4 toxicity, in the observation arm, 1 patient each had urinary tract obstruction, that's ureteric obstruction, intestinal obstruction, kidney injury, and stomal bleed. In the RT arm, there were 4 patients who had intestinal obstruction. For grade 2 effects, there was 7% rate in the observation group and 15% in the RT group, but this was not statistically significant. When we look at time trends of late toxicity, any grade 2 plus, we saw that the late toxicity is mostly similar in both the arms, and there was no statistically significant difference. We did a multivariable analysis for the toxicity, and as expected, the acute toxicity was higher in the radiation arm, but the late toxicity was similar in both the groups. Now, this is the largest randomized controlled trial of adjuvant radiotherapy in bladder cancer. The strength being it is a multicentric trial across India. 90% patients receive systemic chemotherapy, which is a really high percentage. And global consensus guidelines were followed, so this was our standardized treatment. We did pay rigorous attention to radiation safety because toxicity was one of the main concerns when the trial was conceptualized. So everyone received IMRT with daily image guidance. There was strict attention to stoma and bowel during the radiation planning. And a dose of 1.8 gray per fraction was used to minimize the toxicity. There was no hypofractionation. Results are awaited for the primary endpoint of survival, and QOL analysis is ongoing. There was no adjuvant immunotherapy for the reason that most of the patients were accrued before the approvals for immunotherapy came through. And we can expect the results to be reported during the plenary session of ASTRO this year. Thank you for your attention.